Good evening, everyone, and welcome to the October edition of the Scleral Lens Education Society webinar series. So excited to have a wonderful colleague and friend, Dr. Kelsea Skidmore, joining us tonight. She will be speaking on ocular surface disease and rehabilitation with scleral lenses, fitting, and troubleshooting. Welcome, Dr. Skidmore.
Thank you for having me. Excited to be
Yes.
here.
Of course. So Dr. Skidmore graduated from the University of Houston College of Optometry with an OD-MS degree, where her thesis was centered on scleral lens complications. She now sees patients at an OD-MD practice and surgical center with a focus on specialty contact lenses for irregular corneas and ocular surface disease, as well as myopia management in children. Dr. Skidmore is adjunct faculty at the University of Houston College of Optometry, where she participates in research projects with the Ocular Surface Institute involving scleral lenses and myopia management. She is a fellow of the American Academy of Optometry, as well as a fellow of the SLS, where she is actively involved with the Public Education Committee, our current committee. Thank you, Dr. Skidmore. All of her financial disclosures have been mitigated. Just a couple housekeeping-ish topics for this evening. If you have any questions that you would like Dr. Skidmore to answer, please feel free to put them in the Q&A feature or in the chat feature. We'll be addressing them at the end of the webinar. Attendees must remain online for a minimum of 50 minutes for COPE credit. You are welcome but not obligated to stay for the Q&A after, and you will be able to see a copy of this, a recording of this on our website library page later on this week. If you have never joined us for one of our webinars and you would like to get CE credit immediately, please make sure that you download the OE Tracker app in the Apple Store or Google Play Store. All you have to do is at the end of the webinar, I'll put up a QR code, open up the app, scan the QR code, and you will be able to see a confirmation that will appear correctly if you scanned it appropriately immediately. If you're not app savvy, don't worry about it. We will send you your CE certificate shortly after the webinar. Please join us next month for a Spanish webinar. We'll talk about the topic a little bit later after Dr. Skidmore's talk. All right, you guys, I'm going to unshare my slides and I'm going to pass it over to Dr. Skidmore.
All righty. Let me. All right. Let me move this over. All right, we should be good. All right, welcome everybody. So I'll be talking about managing ocular surface disease with scleral lenses. So, and our learning objectives here will be understanding underlying ocular surface diseases that can be managed with scleral lenses, kind of diving into some of the research and literature, case reports, supporting and giving pros and cons to managing with the scleral lenses, and then navigating various hurdles that can potentially occur during or after the fitting process. So most of you guys know about scleral lenses and the geometry. But looking at the optic zone, that is what actually has the desired optical effect. It contains the optics and vaults over the central cornea. Then you go into the transitional or limbal zone. This will vault the limbus, and in some designs also can control the sagittal depth. And then the landing zone, haptic zone. This what really helps with the comforts. What interacts with the actual eyeball itself is a set of 3 to 5 peripheral curves that you can design to aim softly as possible. So you have this beautiful tear reservoir, which vaults over the cornea limbus and can help a lot with these ocular surface disease patients. It has the advantages of bathing the cornea in fluid throughout wear, protect and rehabilitate the ocular surface, can improve vision in the majority of cases, and enhance comfort because unlike some of the corneal RGP lenses, soft lenses, they're not interacting with the cornea at all, only the sclera. We know many of the indications, and most of us are probably fitting for those on the left, more for rehabilitation of the vision. So for your keratoconus, PMD, other ectasias like post-refractive surgery, RK, transplants, those we know, and there's a ton of research on those indications. We'll go over a little bit more of the ocular surface disease patients. Dry eye, just run-of-the-mill dry eye, and then those that have some underlying condition like Sjogren's, exposure keratopathy, and then some of these below. We'll dive into some of the research behind those. So dry eye, as many of us have probably read this Dews report, is multifactorial. So disease of the ocular surface characterized by loss of homeostasis of the tear film, accompanied by ocular symptoms, but we'll look into the different steps, and scleral lenses have become a fabulous tool to really combat dry eye, but are not likely to be a single and only treatment for a patient that is undergoing treatment. It is multifactorial, meaning you probably will have multiple types of treatment to treat these dry eye and ocular surface disease patients. So we'll talk about several of the more severe ocular surface diseases, but they can also be a good treatment and management for some of the milder cases that might have contact lens intolerance because of their dry eye, but don't have any underlying pathology. So one of our first studies we'll look at is one by Dr. Shornack and Associates. They did a retrospective study looking at 212 subjects, 346 eyes, looking at the medical records and reviewing, and they also mailed out a survey to all the patients who completed a scleral lens fitting, so they can evaluate more the long-term success with scleral lenses managing their various ocular surface diseases. These patients averaged a visual improvement of over 2 lines of acuity after having scleral lenses, and all of them reached their therapeutic goals. They had different goals. Some were improved comfort, ocular surface protection, or resolution, or whatever the issue is, usually some sort of keratopathy. That was achieved in all but 2 subjects. The main indications were just undifferentiated ocular surface disease, but they also had exposure keratopathy, neurotrophic keratopathy, Sjogren's, limbal stem cell disease, post-chemical injury, and a few other corneal dystrophies. But the subjects attempted, on average, 3.2 other forms of intervention prior to the scleral lens fitting, but ranged from 0 to 8. So some patients had already tried 8 different things before scleral lenses were introduced. The kind of proponent that these commercially available scleral lenses can be a great option for any ocular surface disease patient to help rehabilitate the surface and improve those symptoms. And then there's Sjogren's, which is a chronic progressive systemic autoimmune condition. Primarily involves immune-mediated damage to the lacrimal and salivary glands, which is why you get those common dry eye, dry skin, dry mouth symptoms that you're going to see with patients. And this pathology translates into the clinical symptoms of dry eye that you are going to be seeing, like your SPK, erosions, insufficient tear lake, can lead to MGD, a reduced breakup time, conjunctival injection, scarring in some cases. It can be either alone, so like primary Sjogren's, or secondary to another underlying autoimmune disease, which is I actually see a bit more common in practice. So you'll be managing at the rheumatologist a lot with these type of patients. So I kind of get a mix of some of them were referred by the rheumatologist for treatment because they're diagnosed, secondary to something else the rheumatologist is already managing. And then some of these patients have no idea. I just keep seeing them back. We've tried plugs, we've tried flails and other things, and still maybe not resolving everything. And that's when I usually refer. I'm like, all right, let's loop rheumatology into this. One we probably all see is exposure keratopathy. So this can happen with anything that causes the lid not to close all the way. A lot of time it's going to be the facial nerve palsy, like ophthalmos. If the patient does have proptosis, so it's not that the lids can't close, the eyeball's just proptotic. Post-surgical, sometimes a blepharoplasties or some other trauma that they might have had surgery, and now their lid is exposing the cornea and drying out. You can get the burning sensation, foreign body sensation. Redness is typically worse in the morning. Sometimes I'll see, almost not sometimes, all the time, you'll see that perfect little band of SVK, that middle to lower area of the cornea and conjunctiva. And you start looking into it. Some of them have no idea that they have black ophthalmos. I had a patient today, I brought that up, and perfect staining. I was like, how's your dry eye? Like, do you open your eyes when you're sleeping? And immediately the husband in the chair behind me is like, yes, she does. So that's when we start kind of talking about different therapies we might do with that, which leads us into this. Topical lidocaine drops kind of first on the line, and then the nighttime ointments. I love the nighttime ointments for these type of patients because scleral lenses are great by day, Sometimes she'll have them wear at night in some of the severe cases, but a lot of times I'll have them take off the lenses and then use ointment at night. Patients either love it or hate it. Sometimes it's too goopy for them, and they prefer to wear moisture chamber goggles instead, or lid taping. Sometimes it goes surgical, and you can use gold and eye weights. I've seen them do like Botox injections, the levator to cause it atosis to help close that eyelid a little bit more, or scleral lenses. Also a great option, as we'll see here. This is a case by Dr. Pullman Buckley of exposure keratitis, secondary to the inability to close their eyelids after an acoustic neuroma excision. So these are a slow-growing tumor along the branch of the eighth cranial nerve, but a lot of times either the neuroma itself or damage from removing it will hit the facial nerve, leading to inability to close. And you can all see it here in A, dense opacification, neovascularization all the way up to the pupil. This is 6 years later in B, you can see it didn't make it go away, but it stopped the vascularization process. It stopped the opacification. It actually looked a little bit less dense. So it halted it and actually reversed a little bit of the damage and improved the vision drastically in this patient. And then limbal stem cell deficiency, also one that responds pretty well in most cases to scleral lenses. So as you know, the limbal stem cells are generally believed to be responsible for maintaining the integrity of the corneal epithelium and for preventing the migration of the conjunctival cells onto the surface. So if these cells are damaged, challenged, destroyed in any way, then the corneal surface might become compromised. These cells don't regenerate, so patients that have limbal stem cell deficiency will be struggling with ocular issues their whole life. Many different things can cause damage to these cells. So whether it's trauma, SJS, pseudocytosis syndrome, ocular cicatricial pemphigoid, contact lens wear, I see anything that diminishes the number of those stem cells can ruin their environment and lead to these signs of corneal vascularization, scarring. You'll start to get ingrowth of the conjunctival epithelium onto the corneal surface, or conjunctivalization, persistent defects, and you'll get this whorl pattern of staining on the epithelium of the cornea. So treatments is again to getting that as smooth as possible and lubricated as possible. They can respond to steroids, reduce inflammation, amniotic membranes, autologous serum, sometimes need a graft, and then scleral lenses. So all of these treatments, the goal is to target and maximize the function of those remaining limbal stem cells. Looking at the literature, kind of mixture of things here, they've been shown to be a possible treatment option. I mean, they vault the cornea, bathe the ocular surface in fluid, and provide a nice little microenvironment for these limbal stem cells to flourish, the ones that are left over. And if there's any scarring irregularity, it also corrects that, so you can get a visual benefit. Study up here, kind of top right, was looking at the clinical management of these cases. They did 27 eyes, 20 patients that completed a scleral lens fitting. The VA improved in a good portion of them, but only 25% actually got an improvement in vision. And then another 50% remained stable, which stable in this case is actually good, but the remaining 25% actually still worsened. So something to think about when you're managing these severe ocular surface disease patients is that you're not going to make it go away. And even with the best treatment, it still can progress because they still have a disease process. These are some of the subjects, actually, their images where the left is where they started with a mild staging of limbal stem cell deficiency, and then they progressed even with scleral lenses. Similar results at this one here on the bottom, looking at with the pros lens, but they got better stats in terms of improvement. So 70% actually improved at least 2 lines of acuity after being fit with scleral lenses, 16% improved, but less than 2 lines, about 10% not changing, and then 3% decreased. So with this pros device, the majority actually had improved VA, but still worsened in their ocular disease despite scleral lenses. The key and some of the conclusions from both of these studies were that while scleral lenses are going to be really helpful in a lot of these cases, they still can progress, and you're really going to have to monitor them closely. These aren't the patients you see you in a year, here's your scleral lens, it fits perfectly right now. You might be seeing them every 3 months, every 4 months, 6 months, depending on the severity of the case. And Stevens-Johnson syndrome, also very similar. So very serious disorder of the skin and mucous membranes triggered by a reaction to medication. It can be many medications, but sulfa drugs are one of the top. They'll start with kind of a flu-like response and then develop this painful rash and blisters that's pathognomonic for the SJS. When you look at the slit lamp, you can get this conjunctivitis. The defects can be anywhere on the ocular surface, cornea or conjunctival, leading to scarring, and then kind of end stage would be more corneal perforation. Like many other treatments we've been saying, anything that lubricates the surface, reduces the inflammation is where we're going for treatment of SJS. As the severity of Stevens-Johnson syndrome increases, you're going to get more dense scarring, neovascularization, get some blepharons or shortening of the fornices that results in more anatomical challenges when it comes to scleral lenses. You can see the stages going from A to B of more the milder stages leading up into more severe stages. These are ones where you may not be able to do larger diameter lenses that we usually like to do because we want to cover more of the surface, protect more of the surface. But if you can't fit a lens in their eye, then you're going to have to go with more of a mini scleral design in some of these. This is when profilometry might be helpful because you might be trying to vault over some of the scar tissue, either on the conjunctiva or the cornea there. This is looking at prose lens, but using the back surface channels. You don't want to have too much suction, so a lot of the time you can use lenses that have channels or fenestrations to get a little bit more oxygen to these very compromised corneas. Using a little bit less these days is still very, very helpful, but we have a lot more high decay materials than we used to, so the risk of hypoxia is a little bit less. This is a case where they fit some patients in the prose lens that had SJS. You can see over time, you started off in this figure A with dense, diffuse neovascularization and haze at baseline, and then you get a progressive regression in the corneal haze over time. B is at 5 months. You can actually kind of see the pupil through the cornea now. By C is 10 months later. Vascularization is not worsening, that haze is slowly diminishing. And by D, which is about a year and a half later, you can actually see the pupil, the patient's vision drastically improving. So definitely something you want to keep in your back pocket for these patients to make their quality of life better, vision, and help the disease regression. And then there's graft versus host disease, another difficult type of patient to manage. This is an immune response where the transplanted donor T cells attack the host antigens after a bone marrow transplant, which is pretty common after that type of transplant, anywhere from 40 to 60% if you look in the literature, either with acute or chronic. Signs are going to be a dry eye, MGD, you can get corneal stromal ulceration and melt, and like many others, the goal is to get as much lubrication as possible, whether it's with drops, topical steroids, cyclosporin, autologous serum, anti-inflammatory creams, and scleral lenses. This is looking at I think this was after just like a day or so of wearing the lenses. This top is where you get all these filaments in a graft versus host disease patient. After wearing the lenses, just already bathing the fluid and having that wonderful little microenvironment is helping the cornea bounce back after that and reduce the filaments. Something else you'll get with graft versus host disease is meibomian gland dysfunction, very, very common, which can lead to a decrease in the tear layer in these patients. So they'll more likely, and we'll talk about this in more detail later, they're a lot more likely to be having deposits and non-wetting issues. Neurotrophic patients, also another lovely indication for scleral lenses. So etiology is basically anything that causes damage to the trigeminal nerve, resulting in corneal anesthesia. So they're not going to feel things as much. A lot of these patients are going to get these non-healing defects and they don't really feel it happening. So many of them don't realize how severe their disease is because it doesn't hurt. Any damage to the trigeminal nerve from along, the trigeminal nucleus all the way to the corneal nerve endings can cause this. It can happen after surgery, chemical burns, herpetic disease is the big one. The goal, again, is to help that cornea rehabilitate via scleral lenses. This is one by Gray and colleagues looking at a case. They had an astrocytoma and they had surgery. The surgery ended up actually involving the trigeminal nerve, resulting in bilateral neurotrophic corneal ulcerations. That's what those top pictures up there. So super sick corneas. Before trying scleral lenses, this patient had done temporary tarsorrhaphies. They did a Botox injection to the levator muscles in order to induce a temporary ptosis, crazy lubrication, lid taping, severely reduced vision, as you can see from the vascularization and opacification. But after inducing the scleral lens wear, this is 6 months later, still some sick corneas, and it doesn't make it go away, but so much of improvement in vision and improving their ocular surface. Persistent epithelial defects can occur with the neurotrophic, but can occur with many other conditions as well. This was a study many, many years ago, actually looking at, it's 14, this retrospective study, I believe, yes, looking at 14 eyes that had persistent epithelial defects. Some of them were Stevens-Johnson cases, some were herpetic, post-transplant, some neurotrophic. They had undergone unsuccessful treatments like tarsorrhaphies, soft bandage lenses, patching, amniotic membranes. And so they were fit with scleral lenses, but they wore them continuously. So overnight wear with these lenses, and they would come in daily for the office for lens cleaning, putting antibiotic into the lens bowl, sometimes autologous serum or steroid, and then reapplied. 8 out of the 14 eyes actually end up re-epithelializing, which is great. But 4 of the 14 suffered from microbial keratitis. So they had the recommendations that to reduce the risk of microbial keratitis, extended wear should be minimal, which, yes, duh. But with premature abandonment, you're way more likely to have it come right back, which when you think about it makes sense. If it just heals, if you take that scleral lens off within 24 hours, it's not robust. It's not really, really on yet. So you need to be wearing scleral lens even a little bit after it's healed, so you don't kind of take 1 step forward, 2 steps backwards sort of thing. Once the defect has been healed for 24 hours, you'll reduce the lens wear to daily instead of overnight in order to reduce the risk of microbial keratitis. That's another case series here looking at 8 eyes with persistent defects. These looked at different sizes, and they didn't have any cases of microbial keratitis. All that were observed, they had resolution, all improved in visual acuity except 1, but all they were successful without any microbial keratitis or significant complications. The average re-epithelialization was 11 days plus or minus 5. So you're looking at about 1 to 2 weeks of wearing the lenses, daytime and nighttime, again, with daily visits with their doctor going in. They did a combination of serum tears and Vigamox. Some of them also did amniotic membrane graft at some point in that too. But kind of their conclusions were smaller defects heal quicker than larger, which it makes sense. Look at the graft here. Your vertical is going to be the size of the defect. Horizontal is going to be days since wear. So the defects that were, 3 to 4 millimeters took 4 to 6 days. As you got closer to 5 millimeters, that took about a week and a half. Those larger ones that were 6 and above are going to take closer to that 2 weeks. They're thinking that because of the exposed stroma and these larger defects, they're more sensitive to the inflammatory cytokines, and the hypoxic stress that scleral lens wear lengthens recovery, was their hypothesis there. So, but they thought it was worth it. Yes, you're going to get some hypoxic stress, but you're taking 2 steps forward, 1 step back. So it's going to take longer to heal, but the benefits outweigh the risk, and they're taking all the precautions by doing the Vigamox to try to reduce the risk of microbial keratitis. What I found interesting was that this wasn't the first treatment for any of these patients. The mean duration of these defects prior to initiation of the scleral lenses was 79 days, plus or minus 27. So these patients had been weeks, if not months, of struggling with these epithelial defects before they initiated sclerals. After the sclerals, 1 to 2 weeks later, they're resolved. So one could argue that initiating scleral lenses a little bit earlier on in the disease process can be very beneficial in this type of patient. I personally don't do a lot of overnight scleral lens wear just because of the risk. Many patients I've seen don't really need it. We can do the ointment and then do this a daily lens. But here's some studies looking into overnight wear and kind of talking about potential issues. Extended wear does come with the risk of hypoxic stress on the cornea under the closed eye conditions. The study up here by Fisher and colleagues looked at that. So they had subjects wear a scleral lens on one eye under open eye situation and just normal blinking. And the other eye, they put a scleral lens on and taped it shut, and then tested 90 minutes later and found that there was edema, primarily stromal, that increased with increasing the fluid reservoir thickness. So moral of that study is if you are going to have a patient wearing lenses overnight because they have to, for whatever reason, you're going to want to minimize the fluid reservoir thickness so that they get less hypoxic stress. So nothing mashing the cornea, you still don't want to do that, but as little as possible. You're not going to fit a 500 micron tear reservoir lens on these patients to then have them close their eyes and sleep in it. So over here, with the beautiful images of that persistent defect slowly going away with scleral lens wear, they fitted patients, I think 3 in the study with the PROS lens. They filled it with antibiotic drops and serum in the reservoirs and noted that the patients did have some edema, but it wasn't detrimental enough to halt lens wear. All of them resolved, no complications, no microbial keratitis, but they did note if it was a patient with limbal stem cell deficiency or poor endothelial cell count, they may not withstand the hypoxic stress of an overnight wear. So again, using your discretion in these cases and kind of looking at, does the benefit outweigh the risk, or do we need to be more cautious? Drs. Fidel and Kramer also looked at some potential contraindications of scleral lens wear, because there's really no big studies looking at contraindications, but they looked at some more relative contraindications or cautions, especially with overnight wear, and found, again, like the other studies, if they're having so like Fuchs, glaucoma, low endothelial cell count, that you really have to weigh, is it worth it in these cases to rehabilitate the cornea? And if you are going to initiate a fit for these high risk patients, you want to get baseline imaging, the pictures, pachymetry, follow them very, very, very regularly to make sure that you don't have any complications. And I can say that's about any of these patients. They're high risk, they have neovascularization. Anyone that has neo, I like to do baseline pictures so that way you can look over time. So baseline pictures documented, very detailed, 1 o'clock, 2 millimeters or whatnot in their charts. So if they do have any changes over time, we can be on that a little bit quicker. But what about dry eye disease? Just dry eye, MGD, aqueous deficient. They don't have any crazy tumors or lag ophthalmos or neurotrophic. Should scleral lenses be utilized a little bit sooner? I mean, they have the advantages of corneal healing, absence of any tear evaporation. I mean, unlike a soft lens, you're not going to be evaporating from that surface. They can't dehydrate like a soft lens. Potentially increased comfort in a lot of these patients compared to their lenses. Looking at the DEWS report, scleral lenses are still at step 3 when it comes to management of ocular surface disease or dry eye disease in particular. But more clinicians are advocating scleral lens use in the absence of any associated corneal irregularities, since you do get this healing effect. And the efficacy with these lenses, if you've seen in the literature, with ocular surface diseases, other than just undifferentiated dry eye, has been covered in many review papers, but not a ton of studies looking at just dry eye. So I found a couple we can look at. This is an abstract from GSLS earlier this year. It was prospective randomized double mask study that recruited 20 symptomatic soft contact lens wearers without any cornea irregularities. They completed the CLDQ8, so it's a dry eye questionnaire, and rated their contact lens comfort and dryness with their habitual soft lenses, and then compared those to scleral lenses after 1 month of wear. So taking soft lenses, patients fitting them into sclerals. The results show significant improvement in their dry eye scores, and then their subjective rating of end-of-day comfort and dryness with scleral lenses when compared to their baseline soft lenses. 45% of these patients want to continue wearing scleral lenses after the study ended. So switching soft lens patients that are symptomatic may be a very good option for these patients. A lot of time we just end up throwing on other drops, switching to 10 different daily disposable lenses, or saying, hey, you might not be able to do anything. And that's the number one reason patients will drop out of contact lenses because of comfort issues a lot of the time. We don't think about scleral lenses sometimes on what we consider like normal corneas. But if the patient's very motivated to be glasses free and wear contact lenses, this might be a great option to offer to them. Another study, this was also an abstract from earlier this year from NCLC, excuse me. They took 18 symptomatic but non-contact lens wearers. So they had dry eye, but they were not wearing any sort of contact lenses at that time. And they had no corneal irregularities and fit them with scleral lenses. They also had significant improvement in their dry eye scores. They also did the CLDEQ8 in this study as well. Rated the end-of-day dryness and comfort. And then 44% of them, similar to the last study, wanted to share their scleral lens details with their normal doctor and continue wear in the future. So these are non-contact lens wearers that were like, this is helping my dry eye so much, I want to start wearing contact lenses. Excuse me. There's some fitting considerations after we've gone through all those different cases, talk about who we might be fitting. Now, some special considerations because it's different with ocular surface disease and dry eye patients compared to someone like keratoconus. I mean, even with keratoconus, you're going to treat the ocular surface and stabilize the tear film. I mean, you should be doing this even if you're just fitting a soft contact lens. Any new patient I see, if I see that they have any blepharitis, dry eye, I usually will be treating that before I even fit them in a soft lens. So definitely want to do that before you're treating something like a scleral. We'll talk about some fit considerations and materials and care to go over. Begin looking at scleral lenses and remembering that they're a tool to manage ocular surface disease. You're still treating the eye disease. We have to explain to patients you're not curing them. It's like if they're diabetic, just because they're on treatment doesn't mean the diabetes goes away. You're just managing it. And a lot of the time, what works for several years may stop working. The body changes. Same thing with dry eye. What might be working needs to be changed after some time to help manage. And the goal of the therapy is to protect the ocular surface and also improve vision when at all possible. And then obviously treating the lids. I feel like lids have become a little sexier with some of the new medications on the market these days. And I'm definitely guilty of not having the patients look down whenever they come in and kind of forgetting about the lids. But if I have a patient that I'm considering contact lenses, sclerals or whatnot, it's good to have the patient look down. And if you see something like this, I take a picture and show them and be like, before we put anything on your eye, we need to treat this first. So whether it's heat compress, lid hygiene, including scrubs, I love hypochlorous acid, adding on Xdemvy or the lotilaner ophthalmic solution that recently came out. It's a twice a day, 6-week medication that can drastically improve blepharitis. I still tell them, yeah, you're going to do this, but you're still going to need some lid hygiene in the future to kind of maintain everything over time. And next, we need to make sure we're optimizing the fit. A lot of these patients are going to have kind of a spongy conjunctiva and are more prone to things like conjunctival prolapse. So this is where you get the negative pressure created under the lens that it pulls the conjunctival tissue into that peripheral space. If it's severe enough, it can actually adhere to the cornea and cause some vascularization, scarring. If you have too much of a vault, either central or limbal, it is thought that it can lead to this. But if you have too little, then you get mechanical irritation of the limbal stem cells or the cornea in different areas. So finding that balance, trying to get about 50 microns limbal area is best, but even with some of the best fit lens, you can still get some conjunctival prolapse. I can think of a couple of patients off the top of my head where we actually had to refer for a conjunctival resection, because no matter what fit, they were still having issues. But then after they recovered, they were able to come back and would fit a very successful scleral lens. You're looking at diameter. I like increased diameter, more coverage, more protection. You see the picture down here on the bottom left, definitely not big enough. It'll be compressing down there on the limbus, where it's laying right there on the limbus there. With the larger depth, though, you're going to be further out. So you might need to start thinking about some toric haptics on these as well. This is where profilometry can come in. You want a scleral lens to fit the scleral shape. You want to avoid any impingement like you're seeing here on the bottom right, but also don't want to have any lift off like you hear on the top left. If the lens is too tight, you're going to get some imprint, sore sensation. If it's too loose, then they'll be interacting with the patient's lids, and they hate that. They're going to say, oh, I feel the lens, I feel the lens. And sometimes it'll look too tight, but if you look closely, you'll see a little fluting at the edge. Sometimes it's hard to see impingement. The patient may have symptoms, but you look and you're like, yeah, it's really not that bad. Always remove the lens to make sure you're staining, and the staining can actually show you a lot of where it's hitting on the conjunctiva or the cornea. So when you're coming in for these follow-ups, especially dry eye patients, I always have them come in wearing the lens so I can see the fit, and we take, CTs on top and everything. But I also want to remove the lenses and stain to see A, how's their underlying disease going, and B, is that fit causing any issues to the ocular surface? This is a study looking at scleral shape, and it's been super interesting. So you get highly asymmetric further out on the ocular surface. And the top here in the green is looking at the limbus, and all around the limbus is pretty symmetrical. You're not going too off scale there, but as you move on to the sclera, between temporal, superior, and inferior, and going all the way to nasal, you get a wider range of toricity. So these are the patients that are really going to benefit from a toric landing zone, or even quadrant specific in certain cases. It is highly asymmetric. Profilometry, we have the eGlyph, the S-map, and the pentacam. So definitely some great tools whenever you're trying to fit some of these highly irregular eyeballs. Excuse me. So when we're looking at material selection, it's important with any patient. If you have a graft or an epithelial cell dystrophy patient, you're going to want a high decay material. With these dry eye patients and ocular surface disease, they're going to have a higher incidence of tear reservoir debris, lens deposits, et cetera, that are going to be messing with the visual outcomes. As for wetting angle, so this describes how the liquid actually spreads across the surface. So the relationship between the liquid surface tension and that with the contact lens material. A high wetting angle means that the surface does not wet well. You're going to get dry eye areas. So you'll see it beads up here in that bottom image. So closer to 90 degrees, poor wettability, it's beating up on the surface. If you have a drop that spreads out, that is a low wetting angle and a good wettability. So with silicone material, you get increased oxygen permeability. However, it's hydrophobic in nature, so it's going to pose an issue of increasing the lipid protein deposits and decreasing the wettability. So that's why we utilize many different coatings and treatments to help with that and get away from some of these non-wetting issues that you see. It often has this kind of greasy appearance whenever you look at it. And it is thought that in dry eye disease cases where there's meibomian gland dysfunction as well, which I feel like almost every ocular surface disease has some underlying meibomian gland dystrophy these days. It's a factor that you get excess deposition of the meibum onto the ocular surface that reduces wettability. And it leads to this kind of non-sharp, light reflex and greasy appearance. There aren't any big studies to my knowledge that have undertaken investigating the incidence of non-wetting issues with ocular surface disease. But just clinically, I'm sure we can all say that these patients tend to have a little bit worse issues than some of the other indications that we're fitting with scleral lenses. This is a great review paper looking at managing ocular surface disease, but in particular, dry eye without these corneal irregularities. We know that we can fit some of these big diseases, but how is it going in patients that have dry eye? I mean, those I mentioned earlier that are dropping out of contact lenses because of their dry eye, can scleral lenses be a good option? And then they go into some of the things we're going to now, and then talking about some MGD and whatnot. This is one of their pictures of a non-wetting surface and why we'll benefit from things like plasma treatment. It's pretty much the standard of care these days when it comes to any RGP or scleral. Almost everything comes with the plasma treatment, then you can change it to other things like hydropeg. But the plasma treatment's not a coating. It is a super cleaner that creates a more hydrophilic surface. The effects can wear out over time, and you want to make sure you're not using any abrasive cleaners. Here's some of the manufacturer recommendations. You're not going to want to remove the lenses from solution, the vials, until they're ready to dispense. And don't leave them on the shelf for months and months. You want to try to dispense these lenses a little bit quicker. Make sure you're not modifying or polishing or using alcohol or abrasive cleaners. A lot of time I'm having them use a multi-purpose solution or a mixture of hydrogen peroxide. We'll sometimes ask if you can retreat. Answer is no, because it can cause the lens to crack and become brittle. Other newer one, it's been out a few years now, is hydropeg. So it's made from the lubricant polyethylene glycol, or PEG. So it's a 90% water PEG-based polymer that permanently is bonded to the surface of a contact lens. This could distribute the tear film by creating improved wettability, lubricity, water surface retention, increases the tear breakup time. It also minimizes the friction and deposits that you get on the contact lenses. It may last, I don't want to say permanently, a very long time. They have their own recommendations. If you do hydropeg, you'll look at the recommendations there and what cleaners, but just making sure you're avoiding tap water and alcohol-based solutions. Another fun one, other than the non-wetting, will be the lens deposits. It's a lovely picture from Dr. Betty that she shared. This is where lipids, mucins, and its proteins are going to be attracted to the hydrophobic oxygen permeable lenses. You can do all the coatings, but sometimes you'll still get deposits no matter what. Protein can be really great. I love this picture showing the before and after. So you can use this every 2 weeks. It kind of depends on how bad the deposits are. So it has two components. You have the sodium hypochlorite, protein A, mix that with protein B, which is potassium bromide. And when we mix together, they produce an oxidative reduction reaction that disinfects and removes the proteins and debris. So if I have a patient that's a super, super high depositor, you're probably using a mixture of different things. Like you're going to be using your normal solutions, making sure that you are rubbing them, but also doing some of these intermittent cleaners to get a really deep cleanse. Also making sure you're using the right preservative-free salines. I always say preservative-free, preservative-free. Patients tend to forget this sometimes. There are since the case reports or small studies looking at buffered versus non-buffered. In theory, they're showing that buffered solutions may match the pH of the human tears better, so it might be more comfortable for the patient. Buffered ones are here that are closer to a pH of 7, so it's matching the ocular surface more. The scleral film and pure lens have borate buffers, and the neutrophil, I believe, has a phosphate buffer. It's more electrolyte enriched, helping mimic the tear film. And then we have our non-buffered. I actually use a mix of all of them, and if patient doesn't do well with one, we switch to another. I give patients every new fit, we give them, actually from the SLS, they have a great resource looking at all the different solutions. I think it has a link to the dry eye shop on there. And I kind of circle the ones I'm giving, but say, okay, use this, don't use this. It gives insertion and removal information on it. But I always have these discussions because if you don't, you get this. So you can get this with any patient, not just this ocular surface, but I'm sure we've all had that patient where you've given them the information. They have been wearing scleral lenses, some of them for 4 or 5 years. This is one of my longtime patients that came in like, things are hazy. And we go over, the solutions, which I do, even if I've seen them 1 week earlier, my tech always confirms what solution, and I usually have them bring it with them too, so I can physically see it. And they had run out, and they were using it was a store brand, just soft contact lens saline. They were using it to clean, store, and fill the lens. And when I say clean, they were like rinsing it off, putting it in the solution, probably topping it off and not disposing, and then filling it and putting it on their eye. Like, well, no wonder you get the solution toxicity. So even these lovely dry eye patients will need repeat discussions every visit to make sure they're using the right solutions, because that can make all the difference. Especially these thick corneas, they're not going to rehabilitate quite as quickly as someone that has great ocular surface. Midday fogging, the bane of our existence. This can happen anywhere. I think of the normal patients without any underlying disease, it can happen about 20 to 40% of the time. The studies are actually showing that you're getting a lot more midday fogging in the dry eye disease patients. It can happen because of lipid dysfunction, so dry eyes, if you have excess clearance, poor lens alignment, it ends up getting these lipid cells in the reservoir. The current thinking, this is some research by the lovely Dr. Maria Walker, says primarily sequestered lipids, proteins, cell fragments, varies from patient to patient, but found that you are getting a higher concentration of these light chain proteins, particularly these wax esters and fatty amides, with the higher the midday fogging score. So looking here at the OCTs, higher score means more dense whenever they're measuring and kind of grading the MGD. The higher the score, the higher that concentration. A few things to troubleshoot. Toward purple curves could help. If the lens is toggling on the surface, having it fit more like a glove can lessen the amount of debris that's getting pumped underneath. Adjusting the sagittal height, so the lower the better with these cases. If you have 600 microns of clearance, you're more likely to attract fog, and when you do have fog, you'll be looking through a more dense fog. So reducing clearance, both sagittal, or central and limbal, can be a beneficial. Adjusted filling solutions, these are ones that sometimes respond well to a thick preservative-free tier inside. But then managing their dry eye. I mean, scleral lenses are so wonderful at treating ocular surface conditions, but they don't directly treat meibomian gland dysfunction, which is commonly associated with all of these different ocular diseases. They're finding more studies. I don't remember which the study actually didn't download that one study, but they did a survey. I think it was Dr. Shornack, their group at Mayo, looking at incidence of meibomian gland dysfunction and midday fogging, and found that it's more like over 70% of patients that were fit and they have meibomian gland dysfunction were getting midday fogging. So if you're not treating those meibomian glands, you may always have deposits in midday fogging, no matter how perfect that fit is. So whether you need to refer out for lipoflow, I've been referring out for more the IPL treatments more often to kind of get everything flowing. And it's been really instrumental in getting these patients comfortable wear time throughout the day. So patient education is key, as we know with any of these, making sure they're washing their hands before contacting. So if they have any gunk on their hands, they're not getting it onto the lens. Digital rubbing and rinsing is necessary. So I always tell them you don't just squirt it off with some solution, making sure you're putting it in the palm of your hand. I will even demonstrate to the patients. I'll put it in the palm of their hand, put some drops of multi-purpose solution in, put my fingers on there, and in their hand, I actually rinse it off so they can feel the pressure. So they kind of know what they're doing and they don't go in blind. But also when I do that, they helps remember, like if my doctor rubbed these in my hand, I'm probably going to remember to rub them too. Making sure not to have oil-based moisturizers getting on the eyelids. Make sure to do any makeup or creams afterwards. But stress the appointment of the follow-ups. Again, they can't just disappear. They need to be coming in. We need to monitor their ocular health. And that even with making all these modifications, they still may not be able to wear their lenses for 20 hours without problems. I usually remind them, you know, you're not your husband, you're not your 12-year-old kid. You won't be able to wear these lenses without problems all day long sometimes because of whether they have any actual ocular surface malformations versus just dry eye, they might always have some fogging because of their underlying meibomian gland dysfunction after 8 hours. They need to take the lens off, or after 4 hours. So I usually set them up to knowing that they might have to be struggle with this. So if they don't, hey, they're a little happy that they don't have to. Other thing is managing patient expectations. These patients are harder. They have a lower satisfaction level with scleral lens wear compared to patients that require scleral lenses for visual rehabilitation. So it can be very difficult to manage their expectations and reminding them, just like earlier, this isn't a cure. This is just another tool to manage your condition. This is a study looking at patient satisfaction with scleral lenses. And they actually did find in the 178 patients, they reported those that had dry eye disease ranked comfort and overall satisfaction lower than patients that had conditions like keratoconus, different transplants, irregular stigmatism, dystrophy, whatever just irregularity, which I concur anecdotally from clinic. I mean, you have that counting fingers keratoconus patient come in. They go from counting fingers to 20/40. That lens may look awful in their eye. They have a ton of deposits. Sometimes they have them in the wrong eyes and they are still happy as a clam and think that nothing's wrong and are the happiest ever. Versus you have that 20/20 dry eye patient that now can kind of wear their lenses longer, but they're not getting that wow factor. So kind of setting those expectations at the beginning is really key. Telling them this isn't going to make all your problems go away. And some of them are very hesitant, especially if they're paying out of pocket and may not qualify for insurance for lenses because you're not getting it for visual improvement. I usually have them for an office visit where we try on a scleral lens, either one eye or both eyes. Let them sit there, like bring up your computer and put lens on and see how you feel. If it helps you after wearing them here for an hour, go downstairs and grab a cup of coffee and come back. Let me know what you think. And if you think you feel like you want to, go through with this, it feels comfortable in the eye, then we'll go for it. This will be another way we help treat your dry eye and get you back into contacts. And then a few of them were like, yeah, it wasn't worth it because it's not like you can pop them in and out. These are patients that tell them it's more of like a lifestyle change. And you have to have your device to take it out. You have all your solutions. Adds a little bit more to their morning schedule. So a lot of these patients are not quite as motivated as some of those that are for visual rehabilitation.